And director of the Effective Care Research Unit, East India, South Africa. He was a professor of obstetrics and gynecology, Coronation Hospital and the University of the Witwatersrand from 1988 to 2000. His research interests includes fetal medicine and improving pregnancy outcomes for women in low resource settings. He has published some 250 articles in peer-reviewed journals, 50 Cochrane systematic reviews, 25 textbook chapters, and 8 audiovisual teaching ornaments programs. He is a co-editor of the Cochrane Pregnancy and Childbirth Database and a regional editor of the WHO Reproductive Health Library. I welcome you, sir.
Thank you very much here today, and good afternoon to everyone. I work in the Eastern Cape of South Africa, which is the poorest province here on the Indian Ocean, not that far away from where we are today. And this is in Dansani Township, the view from the hospital where I work, and the entrance to our labour ward. And I think we share with our colleagues here the belief that it's most important that we do research to be sure that the limited resources we have are used for effective interventions and not wasted on ineffective ones. So over the years, I've really had the pleasure of collaborating with many people from India, and the first such collaboration was the eclampsia trial, where the women recruited for the one part of the trial were all recruited from South Africa and Vellore in India. But today we're not talking about magnesium, we're talking about another divalent element, which is calcium. The discrepancy, let's just go. The discrepancy in the occurrence of eclampsia between well-off countries and poor countries is so absolutely astronomical that it's difficult to believe that this can be purely due to a difference in health services. And so it's very tempting to believe that there must be some biological reason for this, although we have not yet been able to show that for sure. But the first idea that it may be a dietary problem was published in the Lancet in 1952 by an interesting character by the name of Hamlin, who introduced a dietary program in Sydney in 1946, in which he added protein, calcium, and vitamin B1 to people's diets, and he claimed to eliminate eclampsia altogether over a period of a few years of introducing that diet. And he subsequently moved to Ethiopia, where he set up the famous fistula hospital with his wife, and there he noticed that eclampsia was much less common than he expected to be, and he suggested that one of the reasons might have been the local diet, which was high in teff, which also is high in calcium. In the 1970s, Jose Belezan moved from Argentina to Guatemala, and similarly to Hamlin, noticed that local women seemed to have less preeclampsia and eclampsia than he expected, and he wondered whether it might be due to the fact that they had calcium in their diet due to soaking the corn in lime before they cooked it. And this idea resulted in a number of small randomized trials of calcium being conducted, mainly in South America, to see whether calcium supplementation would reduce the risk of preeclampsia. And in 1998, with colleagues including Lelia Dooley, who's sitting in front here, we did a systematic review of those studies, and what we found was that overall there seemed to be a huge effect of calcium supplementation on the incidence of preeclampsia. However, in the biggest study, a North American study, there was no effect. And to understand this discrepancy, there were two possibilities. The one was simply publication bias, because we know that when one has multiple small studies, there's a tendency to overestimate the effectiveness of an intervention. And the other is that the populations were different, because in fact in the North American study, the women had very good calcium in their diet and all took calcium supplements, in addition to the intervention calcium. So to differentiate between these two possibilities, the World Health Organization initiated a very big trial, the calcium trial, and a couple of people are also in the audience who were involved in that trial. And this was in women with low calcium diets. 8,500 women were randomized to receive calcium or placebo in the second half of pregnancy. And when we put the results of that study in the context of the previously published studies, and I hope most of you are familiar with the way that randomized trials are reflected in a Cochrane review, but the individual trials are here, the results are here, the risk ratio is here, no effect is the one line, so anything to the left of that line indicates an improvement. So we see that in trials done in women with adequate dietary calcium, there was no significant effect. That was the big American study, in that the 95% confidence interval overlaps the no effect line. In the studies conducted in women with low calcium diet, there was overall a very big effect, a 64% reduction in preeclampsia. However, the largest study, the WHO study, did not find a significant effect, an 8% reduction, which was not statistically significant. Within the WHO trial, we conducted a small nested study, and what we found was that comparing the 4,000 women who received calcium with those who received placebo, there was absolutely no effect. Let's go back. There was absolutely no effect on markers of preeclampsia, such as the platelet count, serum urate, and urinary protein. And as a result of this, we were left with the following information, that calcium supplementation in the second half of pregnancy appears to reduce the severe complications of pregnancy. This was the important finding of the calcium study, by about 20%. And in the WHO study, there were 1 death in the calcium group compared with 6 deaths in the placebo group. There's possibly a modest reduction in preeclampsia, although the WHO trial did not find that. No effect on markers of preeclampsia, such as proteinuria, platelets, or urate. And interestingly, there was an increase in occurrence of the HELLP syndrome. And based on this, we put forward, again with Lelia Dooley, the hypothesis that possibly the effect of calcium in the second half of pregnancy is mainly related to a blood pressure lowering effect, resulting in fewer serious complications, because we know that severe hypertension is one of the main causes of death and severe complications in women with preeclampsia, but no effect on the underlying pathogenesis of preeclampsia. Because the blood pressure has been lowered, it's possible that women with the underlying process progressing were not diagnosed in the calcium group and therefore more frequently progressed to HELLP syndrome, accounting for the increased observation of HELLP syndrome in the calcium groups. And we therefore wondered whether, if calcium is important in preventing preeclampsia, it might be necessary to supplement women with calcium before they become pregnant and in the early part of pregnancy. And to answer this question, we've mounted a study called the Calcium and Preeclampsia Study, again, with tremendous support from World Health Organization and also from the Pre-empt grant to the University of British Columbia from the Bill and Melinda Gates Foundation. And this study has been running for 5 years, and we recruit women with previous preeclampsia who are not pregnant at the moment but not using effective contraception, and we give them either calcium, 500 milligrams of elemental calcium a day, or placebo, and this intervention is continued until they become pregnant and up to 20 weeks of pregnancy. After 20 weeks, all women receive calcium according to WHO recommendations, because we know that that is of benefit from the previous research. and our primary outcome is pre-eclampsia. As I said, we've been recruiting for 5 years. It's a very difficult trial to do, but we're on track. We've screened 2,500 women, recruited 1,200, and of those, 526 have become pregnant. And so we're nearing our target of 600 pregnant women, of whom 540 we expect to progress beyond 20 weeks, so that we can have the outcome pre-eclampsia. Within the study, we have published one sub-study which was looking at the effect of calcium supplementation on the blood pressure of women with previous pre-eclampsia who are not yet pregnant. The background to this is there's some controversy about whether calcium reduces blood pressure in non-pregnant women. The Cochrane review on use of calcium in people with hypertension found very little evidence and concluded that what evidence was there was probably due to bias. However, a recent Cochrane review conducted by members of our calcium study group of calcium in people, normotensive people, the effect on blood pressure in normotensive people receiving calcium, found a small but significant reduction in both diastolic and systolic blood pressure in men and women who received calcium supplementation compared with placebo or no treatment. So the hypothesis for this sub-study was that calcium supplementation in women with previous preeclampsia is associated with reduced systolic and diastolic blood pressure, and that this effect on the blood pressure is greater in women with previous severe preeclampsia. There's not time to go into the details of the study. We included 367 women in whom we had results up to 12 weeks after randomization without becoming pregnant, and 200 women with results up to 24 weeks. And in very brief summary, and one needs to say that we did many comparisons, so one has to be very careful about the statistical interpretation of the results, but they certainly were consistent with our hypothesis that women with previous severe preeclampsia appear to be more sensitive to the blood pressure lowering effects of calcium. And we will, this was a pilot study which involved only a small subset of the women in the calcium trial. So at the end of the trial, we'll be able to test this hypothesis in an independent, much bigger sample of women from the same study. The other outcome from the study so far has been a systematic review of low-dose calcium supplementation for preventing preeclampsia. And the reason for this is that our previous systematic review, unfortunately, looked only at high-dose calcium supplementation, 1.5 grams to 2 grams in most studies. And therefore, when the WHO recommendations came out for calcium supplementation, the only recommendation that could be given was that women should receive 1.5 or 2 grams of calcium in the second half of pregnancy, which was a great idea, but when it came to the practice of implementing this, the cost and the sheer bulk and weight of all that calcium was a very difficult problem to overcome. So we were interested in the question whether it would be adequate to supplement women with a smaller dose, because 1.5 grams on top of a diet which usually, as we saw in some of the figures this morning that I was very interested in, which usually contains at least 500 milligrams, is very supraphysiological. And so it may be that women need only about 500 milligrams to bring them up to the recommended daily allowance. So we conducted this review and we followed the normal Cochrane methodology. We were looking for trials, randomized trials which supplemented women with less than a gram of calcium with or without co-supplements. And we decided a priori that we would look at trials which included other supplements as well. And very briefly, to look at the results, these were calcium supplementation alone. These were calcium plus vitamin D, and these were calcium plus linoleic acid, which hasn't been shown independently to have a major effect, and calcium plus antioxidants, which also haven't been shown independently to have a major effect. And there was considerable consistency amongst all these trials, which was very similar to the smaller trials of high-dose calcium, showing overall about a 70% reduction in pre-eclampsia. And this reduction was present in all the trials. There was a significant reduction for all the high-quality trials. Not all these trials were very high quality. And there was also a significant reduction in all the trials which studied calcium alone without co-interventions. One interesting finding was in one of the high-quality trials, and this was the only trial in which women were recruited early on in the pregnancy at 8 to 12 weeks, was that there was an unexpected trend to reduce miscarriage. It was a very small study. 1 out of 29 women in the calcium group compared with 8 of 31 in the other group had miscarriage. But that was the first time that calcium had been, I think, really thought of as a possible factor in the risk of miscarriage. So in conclusion, the available evidence supports the probable effectiveness of low-dose calcium supplementation. The trials were not of, the evidence is of low quality and does require future research. However, if one is in a situation where it is just not feasible to offer women the WHO recommended high dose of calcium, it's reasonable to assume that a lower dose may be better than nothing. So in summary, there's an epidemiological association of dietary calcium or deficiency with preeclampsia. Calcium supplementation in late pregnancy reduces preeclampsia by 64%, but not in the largest trial. It does appear to reduce severe morbidity by 20%. Also, what I haven't mentioned in those studies, there was of borderline significance, a reduction in preterm birth by 10%, perinatal death by 14%, childhood systolic hypertension in the offspring by 40%, and childhood dental caries in the offspring by 25%. WHO do recommend calcium supplementation to pregnant women with low dietary calcium intake, and there is ongoing research to determine whether pre-pregnancy supplementation will reduce the more dramatic epidemiological difference with which I started this talk. This is some of our calcium and pre-eclampsia group, to which who I would really like to acknowledge, as well as all the people who've worked with me on the various studies that I've presented. Thank you very much.
Presenting on community level intervention for pre-eclampsia. He is currently Professor of Obstetrics and Gynecology